now, and we grab their urine right now, the blood that you draw right now better match what you sent down on admission 2 days ago. Does it make sense? If it does, you're in the clear. If it doesn't, it was nursing's issue. If the blood you sent down doesn't match the unit of blood you sent down to the lab that caused the reaction, remember what I said, the tubing and the blood has to go back down to the blood bank. That's written there right there. It says, recheck cross-match record with unit and send that blood bag and tubing to the lab. When that blood comes down to the blood bank, they're going to take that brand new fresh blood that you just drew and match it all over again. If it doesn't match, it's on their side. Do you see how that works? Who did what is what's trying to be figured out. We're not trying to play a blame game, but somebody just died, y'all. Somebody just died or came close to it. So we got to know, how did that happen? In a rare sense of imagination in my life, I've never seen it. I hope I never do. But I'm trying to give you the scenario where it could happen. This happened when I was a nurse with urine. I'll give you a good example of how labels, sticky label stickers that go on the shit may get mislabeled. I'm walking in the room. I'm charge nurse. I'm coming on day shift. Night shift has been busy as hell and short. That's typical. They got 4 people in the exam room, 4 patients, all of them with big bellies, babies doing whatever. Monitor on, bop, 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 you can hear the heartbeats coming out of the room. I walk in the room, took my report, walk in the room. I see that the one patient is on the monitor. They tell me that she is, here because her baby wasn't really moving right or whatever. I get her results. It says positive cocaine. I said, oh my God. Now, in the 80s and 90s, that kind of happened every day. So I'm walking in. It's kind of like you get used to shit. We got used to cocaine in the 80s and the 90s. Y'all gonna get real used to heroin. So I walk in the room with my patient, and I say, okay. Y'all know I'm kind of crazy, right? All y'all? That's okay. Man, your urine came back positive for cocaine, which means we are going to put a baggie on your baby when she or he is born. And if their urine is positive for cocaine, you will not be going home with your baby. Oh, she freaked out. She freaked out. She started crying. She started shaking. She started saying, no, I don't use cocaine. You're crazy. What are you talking about? I don't do drugs. That's not me. I would never. Da, 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 da. I said, oh, okay. Now, folks be lying. Y'all know folks be lying. However, something about this woman made me take a step back and go, what if she's telling the truth? And we've destined her to a possible social worker consult, baby not going home with her, all this nonsense. So what do? I said, you know what? I believe you. Let's go pee. Come on, let's go. I'm going to get you out the monitor. Let's go pee. We put it in a cup, put it in the tube. I let her watch me. I let her watch me put the sticker on it. And I sipped it, and the damn thing was negative. Now, I don't know who upstairs with cocaine in their system, because we never did figure that out. Somebody upstairs going home with their kid. They just did coke and it's all good. We don't even know who that was, because this lady's urine was labeled incorrectly. It happens. I swear to God it happens. What if that was her blood? What if that was a type and cross? What if she bled on me during delivery? Because she was pregnant. What if she delivered and bled? I have to believe that her urine and her blood were probably mislabeled. So I drew the blood again. I did everything. I was like, we ain't finna have this. So I did it all over again. But you have to accept that in a non-perfect world, that's the kind of shit you're up against. And it's kind of like human to error, but it's deadly in nursing. It's human to error. I mean, we're human, but it's deadly in nursing. Okay? So you have this patient, and you gotta know, hemolytic transfusion reaction is very rare, but it's very fatal. And it's DIC, and it's renal failure. It's really bad. Okay? So what you want to highlight on the white sheet with this transfusion reaction, I want you to highlight a couple of things. I want you to highlight low back pain. Where it says hemoglobinuria, put dark urine. Add high fever. And put number one cause is human error. This is an incompatible blood. This was incompatibility. Because it was incompatible, you had an antigen-antibody response. I would probably put stars all around that word, that phrase, antigen-antibody response. Okay? Now, when it comes to a febrile reaction, that is very, 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 very common. Febrile reactions are common. So are allergic reactions. For the febrile reaction, I want you to highlight the word chills. There's a word I want you to add. Next to the word chills, I want you to add rigors. It means the same thing, but it may just be vocabulary, semantics. So you just want to add rigors. This is a sensitivity reaction. It is the number one transfusion reaction, and it is not fatal. Now, I'll tell you when this happens, because this is all stuff that we do. This happens when you let blood sit too long, like the girl who didn't give it right away. We give platelets at room temperature, and they have a tendency to cause a febrile reaction as well. So platelets, because we give them at room temperature, and as you know, bacteria can grow. This is a break in aseptic technique. Okay. The allergic reaction, the most common blood product that can give you an allergic reaction is platelets. 1 in 30 patients that get platelets will have an allergic reaction. This too is an antigen antibody type of reaction, just not as severe. I need you to add to your allergic reaction on your white packet, wheezing. That's the number one sign, wheezing for allergic reaction. I want you to add that word and then highlight bronchospasm. So a respiratory type of change is going to be a red flag for an allergic reaction, wheezing. So let's make sure we got that right. Hemolytic transfusion reaction, deadly. Going to be an issue of DIC and renal failure. Going to be incompatible blood given. This is going to need some quality assurance kind of investigation. Who did what when. So the tubing, the blood, a new sample of blood from your patient, a urine specimen from your patient. All of that is going to go down to the blood bank for analysis when your patient is either stabilized or unfortunately gone, okay? The allergic reaction is very common with platelets. It too is an antigen-antibody response like hemolytic blood transfusion. We often will give an antihistamine for the allergic reaction. Any antihistamine will do. I think I might have written a few on your pink packet. Did I write some antihistamines? Yes. I wrote chlorotrimazine, but you know the number one is Benadryl, right? So you could give Benadryl for this. This is one of the transfusion reactions that the physician, once you gave the Benadryl or the antihistamine, might say, okay, restart the blood, and that makes sense. So you initially stop the transfusion, but if we can give an antihistamine, your physician may say, and is definitely okay with me, to restart the blood, because this patient will die without the blood. It's a last resort anyway. We don't just order blood like Kool-Aid. So reality is, as long as you covered her or him with an antihistamine, we can still give the blood, but you made sure you covered them. It's so important to know this is one of the few you can restart the blood. Okay. For the febrile reaction, the most common reaction here, you wanted to remember rigors. It is a sensitivity issue, usually a break in aseptic technique, or maybe giving blood that is sat out too long. Now, those are your three major ones, agree? Okay, but here's a fourth person that you say, you know what, let me stop the blood. It's going by the patient's comments. You're sitting at the bedside. How long are you sitting at the bedside with this patient? 30 minutes. And your patient says something crazy. I don't feel right. I don't know. Well, what do you feel, sweetheart? I don't know. I just don't feel right. Oh, I'll never forget that because it happened in my class. So people that talk like that, I don't know. All of a sudden, I don't feel, stop the blood. The student who said it in my class was having an anaphylactic reaction, coded, was flown, life flighted to Metro. What was it? Peanuts. She ate peanuts every day, but this day she decided to have an anaphylactic reaction. She had peanut M&Ms and used to sell candy. Peanut M&Ms every day. This is years ago. And matter of fact, Dana, you might have been in that building. Yeah. And she ate the peanut M&Ms, and thank God my daughter was here because, you know, I broke every child labor law. She probably was 13, y'all. Y'all pray for me. But she was a kid, right? She was selling the candy. She was out in the lobby. And this little girl got up in the middle of class and walked out, and she sat down in front of my daughter and said, I just don't feel well. And my daughter said, huh? She's 13. She said, I don't know. I don't feel well. My daughter came around to the class and said, Mommy. And I went around there. I said, what's wrong, honey? She said, I don't know. I just don't feel right. And I said, well, what were you doing right before? I wasn't doing anything. I was taking notes, and I don't know, I was eating my M&Ms, and I said, have you ever felt this way before? Yes, when they gave me penicillin. That's it. Call 911. Because what do we know about penicillin? Anaphylaxis. Okay? So this is why you still have to go by your patient. If they say, I don't feel well, I don't know, I can't explain it, stop it. Stop the blood. Okay? All right. Now, so that's that. Now, of course, this is such an important issue. If you turn the page, there is more of the same. On your white packet, you have a bunch of stuff. Same shit, different day, but we're just going to do some big things with this. You're going to take your allergic reaction, and look how big I wrote the word wheezing. Look how ridiculous I wrote that in red, no less. Allergic reaction, I wrote wheezing in red. Big as I could. For febrile, I wrote chills and rigors as big as I could. Highlighted the rigors in pink. Did all kind of crazy stuff. For hemolytic, I wrote low back pain. Really big. Okay. Now, I want to write a couple things on this page, just some things that you should know. Number one, the risk of getting HIV with blood transfusions is not zero. It is very low, but it's not zero. And you had to know that since 1985, please make sure you know that date. Since 1985, we have been testing all of the blood for HIV. It is not impossible to get hepatitis either. It's rare, but it's not impossible. And for this date, you want to put 1992. Since 1992, we have been testing the blood for hepatitis. So, Shelly, you say it's not impossible. Well, give me some numbers. You don't have to write this, but I'm trying to put a backdrop to it. 1 in 2.3 million will still get HIV from a blood transfusion, versus 1 in 350,000 will get hepatitis. Notice it's not impossible. There's that little window of opportunity where we don't know what you are yet, and our test has not been able to pick up your HIV yet. We have not gotten you to seroconvert. So just know that. Don't lie to people and say, oh, you can't get HIV. Don't you hear people say, you can't get HIV from blood transfusions no more? Yes, you can. It's just super rare. Okay? I don't say impossible. Ain't shit impossible. Okay, now, other things that you have to watch for when we're doing a blood transfusion, and that's why I like this sheet, because you have a little bit more room. You have to watch the potassium. You can have hyperkalemia with the blood transfusion. Hyperkalemia with blood transfusion. You have to monitor for fluid volume overload. Fluid volume overload. That's a big one, especially if you're dealing with somebody who may not have the best kidney function because they're not getting a good perfusion. So I want to give you like a list, shall we say, like select all list of fluid volume overload symptoms. You probably know them already, but we're going to hook you up. High blood pressure, so your blood pressure goes up. JVD, tachycardia, headache, shortness of breath, crackles, patient is restless, What's the quality of the pulse, everybody? Bounding pulse. Edema, weight gain. So there you go. Okay. All right. Now, so that's that.